Welcome, everyone. Thank you for joining us. My name is Melissa Warner, Executive Vice President at HealthCom Media, publisher of American Nurse Today and several other healthcare-related websites and journals. I'll be serving as your moderator for today's educational presentation. Our topic today is Transformative Leadership, Navigating Teams Through Change. We have two presenters today. Dr. Kathleen M. White maintains a joint appointment as a clinical nurse specialist at Johns Hopkins Hospital, where she is a member of the EBP Steering Committee and an original part of the Collaborative School of Nursing Johns Hopkins Hospital team that developed the widely published award-winning Johns Hopkins Nursing Evidence-Based Practice Model and Guidelines. Joining Dr. White is Deborah J. Baker. Dr. Baker is the Senior Vice President for Nursing for the Johns Hopkins Health System. Deborah also serves as the Vice President of Nursing and Patient Care Services for the Johns Hopkins Hospital. As the health system's first Senior Vice President for Nursing, Dr. Baker partners with the Chief Nursing Officers at the other hospital locations to ensure integration of services and alignment with the health system's strategic goals and objectives. Johns Hopkins University School of Nursing brings this educational program to you. We thank them for their support. Now I'll turn it over to Dr. White.
Thank you for that nice introduction. And I'm happy to be part of this webinar today on transformative leadership. We'll be talking about leading transformation for value-based healthcare. The goals of this webinar are first to discuss the need for new leadership approaches in the context of our value-based healthcare delivery. Second, we would hope that you would be able to understand the macro, meso, and microsystem frameworks that we're dealing with as we lead these transformations. And finally, we're hoping that you'll be able to describe transformative leadership strategies to lead change within your organization. So healthcare delivery services here are currently in great transformation. New competencies are required for clinicians, for managers, and for administrators in order to really navigate effectively in our healthcare delivery and succeed under value-based and population healthcare delivery initiatives. Leadership does not just rely solely on individual characteristics and attributes in those formal roles. We saw many leadership styles emerge that brought about significant change in the 20th century. And unfortunately, or fortunately, whichever way you want to look at it, we need new approaches for leadership in this 21st century because of our focus on creating value and improving health. And so the idea of transformative leadership needed for the changes that we're seeing in healthcare today depend on relationships and interactions, that concept of collaboration, and the principle of shared leadership among colleagues and professionals. And so we're really looking for a call for new forms of leadership. So what is value-based healthcare delivery? I know it's something that you're all living every day in your organizations, but it just so that we're all on the same page, it's a healthcare delivery model where providers are reimbursed based on patient health outcomes. So for example, a value-based healthcare delivery agreement would reward providers for helping patients improve their health, reduce effects and the incidence of chronic disease, and hopefully live healthier lives as they try to reduce those effects and incidence of chronic disease. The benefits extend to patients, providers, payers, suppliers, and society as a whole. Value-based care differs from our fee-for-service or capitated approaches that we've lived with for many years, where providers are paid based on the amount or the volume of healthcare services they deliver. So the value in value-based healthcare comes from measuring health outcomes against the cost of delivering those outcomes and attempting to improve health. I'd like to turn this presentation over now to Dr. Baker, who's going to talk to you about nursing leadership now and two of the approaches that are so important for our healthcare organizations and how we approach transformative leadership.
Thank you, Kathy. So Kathy has introduced the need for transformational nursing leadership. And so what does that look like? And where have we been and where are we going? I think are the basic questions. And what is needed? So I think up until this point, we really have been teaching our nursing leaders more about adaptive leadership, how to respond, how to manage, how to pivot in today's in changing healthcare systems. The value-based care calls for a nursing leader that can lead and be transformational. It's a different calling. And the way to present this, as Kathy had alluded to, we want to present this looking, kind of breaking it down into the layers of what you're leading, who you're leading, how you're leading, looking at taking a system approach, the meso system and micro system approaches. And then I'm going to hand it off to Kathy, and she's going to tie it up for us around what does it look like at the macro level, the how will nursing influence organizational and societal healthcare transformation. So we will be talking about a few frameworks and kind of guiding principles and hopefully connecting some dots for you. So if we start at the meso system, one of the goals of a meso system for transformational leadership is to create a healthy work environment. That healthy work environment is not just for employees working in a nice place to work, if you will. Healthy work environment is defined by the AACN and other organizations as an environment that promotes safety, transparency, and develops professionals, providing high-quality care. So some of the goals of a healthy work environment include, and are very important to nurse leaders, preventable harm, precision and population health, kind of the triple aim philosophy of right care, right patient at the right time, quality outcomes, the patient experience, and strengthening the value proposition of nursing care, which I'll go into in a little bit more detail. But these are kind of the big goals of transformational nursing leadership. So we'll talk about a couple of these guiding principles or frameworks in which a healthy work environment is established. We'll talk a little bit about high reliability principles, just culture principles, and the patient and caregiver-centered care that is critical in that collaboration that Kathy had alluded to. So when you think about high reliability, these become buzzwords unless you really do understand their impact. Some guiding principles of high reliability, and those industries are not just in healthcare, right? We see it in aviation, in the military, places where we have to be precise and safety is really critical. So these are the principles. Preoccupation with failure, you're always thinking, what's the worst thing that can happen, and am I prepared? Leaders really need to have that front of mind, top of mind. Reluctance to simplify, not to minimize issues when they're brought to you by the front line, like really peel that onion, understand all causes. Sensitivity to operations, especially in healthcare. These are not factories. People are messy. Everybody involved in healthcare brings all their own baggage to that situation. And just like there may be one diagnosis, but every patient manifests that in a different way. So sensitivity to the complexity of everyone involved in an operation and or workflow, and considering the impact of each one of those factors. Commitment to resilience, a commitment to your staff and to your organization that you will have things in place to be able to deal with high stress events, to be able to debrief, to be able to talk about what does it look like when things are going well and how can we support that process. especially in healthcare where you're dealing with vulnerable populations and staff that have varying levels of expertise and experience and education. So commitment to resilience is critical. And then deferring to the experts cannot be overemphasized. And this will come up again when we talk about the value proposition in nursing. And that is allowing the people that really know the content, really have the knowledge, help drive decision making, deferring to them for the right answers. Another guiding principle that contributes to creating a healthy work environment where you can transform and adapt to change is a just culture. And really, what that means is what this says. It's creating that atmosphere of trust and transparency where people are empowered to speak up and share essential information, and that there are clear lines of expectations of what is acceptable and unacceptable. And I would say, to take that one step further, that in a just culture, interventions are applied equally for the same performance issues. So you wouldn't treat a physician different from a nurse than from a housekeeper in terms of how they're contributing to the organization or having performance challenges. That's the just culture. I know what to expect with my performance and what the consequences are. And finally, patient and family-centered care. I think Kathy alluded to this, that this is so critical when we're talking about the new nursing leader, moving from adaptive to transformational. What nursing can bring very uniquely is the patient and family to the table for shared decision-making. And the table is obviously a metaphor, but whatever care environment, whatever venue, involving patients and families and caregivers into the early decisions around what to do next in care, it allows them to help design and to own the outcome. You will see much more adherence and compliance around treatment recommendations, engaging them at the very sharpest edge of care. Equally as important, though, when you're thinking about transformational leadership within an organization, is that you want patients and families that want to be a part of your organization as part of an advisory. And, as members at the committee level, at the work group level of making decisions around policies, recruitment, research, facility design, like there's no small detail enough for a patient advisory. Again, just like your staff at the front line, your patients and families that are our consumers, our customers, give us the best advice around designing policy or infrastructure. So let's talk a little about the nursing value proposition. So I think the best way to frame this up is that traditionally is to give like a pre and a post kind of scenario. So traditionally, nursing leaders in planning for staffing or any kind of programming where nursing care is involved have been given budget information about how much they have in their budget, and then having to fashion that care in order to hit that financial target. Really a cart before the horse scenario, backing into dollars instead of coming up with the best plan for patients. And I think what I had said before about really being at the cutting edge and being the expert that really understand what is required in using nursing labor as the example for a program and to deliver safe care, the experts will know what kind of skill mix you'd need, the level of nursing care that is required, as well as a number of people required to care for patients. Nursing leading that, educating the finance and administrative personnel that this is what we would need to deliver this care, and then having that really important dialogue about, well, these are the financial constraints, and then working together to figure out, okay, so we've done a risk assessment. What can we still do with what we have? And how can we deliver the safest care with what we have? So it's more of a dialogue. It's really deferring to the experts to make that decision. This requires a nursing leader that is financially literate and not just understanding the numbers that are handed to you monthly, asking the question, actually handing to finance, this is the model of care. How can you help me get there? This is what we'll need. really kind of leading that conversation. The other piece of this is to also say we need to invest in retention programs. Retaining staff is there's a very clear ROI around retention of very highly skilled staff, and being able to articulate, if I turn over an ICU nurse within 18 months of hiring, that's $100,000 loss. And then what's incumbent upon nursing is to continually to look for innovative ways to orient, train, and deliver care. That is on the nursing leader. We can't just go and say, this is what we need and you need to fund it. We need to be able to say, okay, well, if we can't do that, how can we do it differently? And who else can we engage outside of nursing to help deliver that care? And that circles back to involving that patient, family, and caregiver to partner in care, because we're all in this together to hit these goals. And there's a lot of things within nursing around retention that are nursing specific in terms of recognition and developing professionally nurses so they will stay with an organization, understanding the development needs of your staff. All of that rolls up into the nursing value proposition. Investing in talent, and that is committed to your organization pays huge dividends, and nursing leaders need to be educated in that way. So that was like the meso system. That's like looking at your organization with some guiding principles about how do I want to move this diverse workforce forward, and how do I educate executives to invest in this great asset. Let's talk a little bit about what the nursing leader needs to do at the microsystem level, and that's really about focusing on your workforce, kind of what is really in the purview of nursing leaders. It's really about developing professionals and creating bench strength. It's really important. I think we get behind the eight ball and we look and we say, oh, we're having turnover, retirements, and we don't know who's gonna lead next. And I think that really pulls in the question of, are we personality dependent, or do we have good processes that are in place? Do we have great succession planning? Are we creating leaders are we developing leaders that are accountable, can be autonomous, and have authority? Can they make mistakes and then learn from them? And will we stand behind them? Do we encourage them to be innovative and very engaged in organizational goals? Old conversations were, well, this is what administration told me I had to do. I like to look at a nurse leader and say, you are administration at every level. And that all those things, an educated and diverse workforce, highly accountable, autonomous, with authority, innovative, strengthens that value proposition of nursing care that you can communicate as you manage up. So, how do you do that? How do you develop people? There's some guiding principles to this too at the micro level. Using inquiry instead of judgment, asking questions, encouraging nurses at all levels to ask why. Why are we doing it this way? Can we do it differently? What's the evidence? And really listening with intention and learning. That's how we develop leaders, right? Leaders are people that don't wait for a script and implement. They come up with their own ideas, and we let them make mistakes, and we let them ask more questions. This requires a significant amount of emotional intelligence. I think that's there's other buzzwords in pop psychology right now, but it's really critical. It's really important to understand for people to be self-reflective about their own strengths and weaknesses, and building their teams to complement that. Not everybody needs to be a charge nurse, for example, but that person may have strengths that are needed elsewhere in the organization. So really knowing your teams, developing their strengths, and minimizing their weaknesses. And then understanding as a nursing leader that in these diverse work groups in any unit or any care area, that there are generational differences. And that, again, is not just the stuff of pop culture. That really is important. And when you're building teams, you do have to meet the needs of someone that's about to retire and someone that is just learning. And it does take quite a bit of emotional intelligence to be able to do that and to be sensitive to that. And not all teams are the same. And that's that situational leadership, right? Where some teams you really have to coach and be on the sidelines, and others are very high functioning and you have to let them lead. All of us are going through great change. I think the three areas here I just talked about: inquiry, emotional intelligence, building teams, understanding those teams, are foundational for change management. But even the most high functioning teams, though, struggle with change. We know this. There's been a lot written about it. So, what can I give you today that's helpful? I have to tell you, what's worked for me is the William Bridges model. Through so many changes, whether they're structural, we're moving large groups, we're changing programs, we're shifting resources, whatever that change is, this model really does help to guide that process. And at the core of it, and I invite you to read William Bridges' model. It's a really quick read and very easy, and it gives you some really great scenarios. But at the core of it is that people are not afraid of the new thing. They're not afraid of the change. They're worried about what they're losing. So just like any other grieving process, it's about the loss of the familiar. What am I going to lose? And you need to have people go through that process, visualize that process, visualize that loss, and understand what that feels like. And it's not say get over it; it's make room for it. And then they're more willing. They feel trusted. They feel grounded. That someone has taken seriously that they are giving up something, and they're more willing to be open to try the next change. And a lot of that is about really being able to draw the picture of what does it look like when we get there. So that is really kind of the meso and micro system frameworks and some guiding principles that nursing leaders today really could help them to be transformational. And I'm going to hand it over to my colleague, Dr. White, and she's going to help put this in perspective about taking the nursing impact at the unit and organizational level and take it to the macro level where nursing leaders can really influence public policy and healthcare more broadly. Kathy?
Thank you, Dr. Baker. And it was really important, we felt, in making this presentation that we included the macro system because it's really driving these transformational changes that we're all seeing at the organizational and lower levels of healthcare and unit level, and several that are extremely important, and where nursing has, I think, been a driving force of implementing changes that we're seeing in healthcare today, are here on this slide. And it's, I think, one of the most important things in looking at these goals is that we have a more highly educated nursing professional. These goals all strengthen the value proposition for nursing in the evolving healthcare system. And first, let's look at the triple aim that was originally designed by the Institute for Healthcare Improvement and now adopted by the Center for Medicare and Medicaid Services as the major focus for Medicare and Medicaid programs and how they reimburse for those services. And so when we think about the triple aim, we're looking at improving the experience of care, improving the health of populations, and then reducing the per capita costs of healthcare, hopefully because we've improved the experience of care and improved the health of our populations. And this triple aim drives many of the programs and the changes that Dr. Baker spoke about at our organizational and unit levels. And because of the triple aim, we have a huge emphasis or focus on care coordination. It was a part of the Patient Protection and Affordable Care Act, the idea that we need to move to more coordinated, high quality care that is focused on our person, on our patient, their family, and the populations that we are serving. And so you think about the right care at the right time and the right level by the right providers. And each time this discussion comes up for care coordination, nursing is there right at the point of care 24/7, and they're driving this care coordination. It really is in the nursing realm. And so as a major policy that has been developed at the federal and at state levels for care, nursing has a major role in providing that care coordination. And so they need to be at those policy tables, not just at the implementing tables, at the policy tables, sharing their expertise, why we can move to a more a coordinated care, why right care at the right time is so important, and sharing their expertise and driving the changes. Both of those goals are aided by the goal of the electronic health record to put crucial patient information at providers' fingertips, allowing the individual provider to see results of care and procedures performed and prescriptions written and other orders that are put in the record by the entire clinician team. And this data sharing has the potential to reduce redundant care and the associated costs that go along with that. And hopefully, let's get back to the triple aim, improve the experience of care and the health of those populations. So you can see how these three, very high level policies are interrelated and are a part of our everyday evolving healthcare delivery system. And so nursing has to be at the forefront in leading those changes. And so when we think about the strategies that would come along with those goals, the goal is straightforward and it is ambitious, that we replace the nation's reliance on a fee-for-service care that really is more fragmented with this comprehensive coordinated care that has payment models that hold organizations accountable for cost control and for improvement in quality. How do we do this? That's the big question that we all face every day in our leadership practices. We as leaders have to be able to translate these new policies and create an opportunity for nursing to lead the initiatives. So consider a couple of them. Thinking about evidence-based care. Under the new models, providers are incentivized to use evidence-based care and engage patients in that shared mutual decision-making that Dr. Baker talked about their care. And that's done by educating patients. And this is an area where the nursing profession, really where we've owned it and excelled for years in patient education. Another example under evidence-based care is also the care coordination. When patients received appropriate care that's coordinated and it's effective and evidence-based, we're all rewarded, the providers and patients and the entire healthcare system. But again, this care coordination is a nursing domain. We can also talk about something called hospital-acquired conditions. I'm sure you're all very familiar with those and how important they are for our practice. And those are conditions that can develop in a patient when they are hospitalized in some form of acute or even rehabilitative care, that if evidence-based strategies are used, can potentially be prevented in most cases, and sometimes result either in accidents or poor standard of care, things that we all are familiar with, like falls and pressure ulcers, things like that we need to be able to prevent by implementing evidence-based care and moving patients to the right level and through the system and getting them out to a community-based level of care where maybe they aren't at as great a risk for developing those hospital-acquired conditions. We think about patient experience. That was one of the triple aim goals. There, we really have to think about changing our processes to create a better patient care experience. Things like asking patients, did nurses explain things in a way you could understand? Did patients say that they received help as soon as they needed it by ringing a call light or calling for assistance? Was the hospital staff able to help them manage their pain? How well was it controlled? And education about medications and treatments and the side effects that they might experience. Those are all things that we're interested in knowing how the patient felt about their experience in care. That's part of policies. We are measured on it. We're asked to improve those kinds of things. And again, nursing at that point of care 24/7 has a big impact on that. And finally, preventing readmissions. Again, one of those things that if we used evidence-based care, we are able to coordinate and put the patient at the right level with right resources and do appropriate discharge planning, educating them through the patient experience, we can hopefully prevent readmissions. So you can see where the translation of these policies in our healthcare delivery system and the opportunity for nursing to lead in these spaces are all interrelated. Think about the value proposition for a strong nursing department, preventing CLABSI, preventing CLAUDI, preventing VTE, early identification of sepsis, and providing education around preventing stroke or getting stroke care as soon as necessary when symptoms arrive. There's just a really strong proposition for nursing to be a part of these spaces. And nursing leadership has to transform how care is provided and delivered and lead the changes. So I'm going to leave you with some thoughts here when you think about the needed transformative leadership in this evolving healthcare department, healthcare delivery, excuse me. John Quincy Adams, one of our early presidents, said, if your actions inspire others to dream more, to learn more, do more, and become more, you are a leader. And those were the leadership approaches that we have seen in the 20th century moving into the 21st. But now I'm going to suggest to you that we need to think more about the transformation that leaders have to be able to provide, building stronger trust-based relationships within our staff. Create a vision for that future of healthcare delivery and nursing's role in it. And how do we then motivate people to buy in and support that delivery of the vision? Only by encouraging their participation and building commitment among the staff. And what I would say, we have to manage the delivery of that vision. Often we create vision, mission, goals and objectives, those statements, and they sit in a nice strategic plan in a notebook on our wall. And I think through transformative leadership, we need to manage the delivery of that vision. How do we do it? Well, by sharing information with our staffs, how they are a part of that delivery of the vision. Communicate to them the measurement of goals, the improvement of care and experience, and how important they are in leading that delivery. We also, as I think was mentioned by Dr. Baker, have to find new ways to solve the problems that we're facing and make mistakes. That's okay, but learn from them. And only through that kind of action can we truly transform our healthcare system and be the transformative leaders in nursing that we need to be. So thank you very much for participating in this webinar with us. And we look forward to questions that you might have for us.
Thank you so much. Thanks to our faculty today for a very informative presentation. We do have time for just a few questions for Dr. Baker and Dr. White. The first question is related to stay interviews. Actually, it's a couple of questions. Is there a template for stay interviews? And what is the recommended frequency for the stay interview?
Sure. This is Deb Baker, and I'll take those questions. So there's a lot written about stay interviews, and one book that comes to mind is Richard Finnegan wrote a book, Stay Interviews, a management tool for keeping the best and brightest, something like that. Don't quote me for the exact title, but if you were to go to Amazon, you would be able to find that. And he does have templates in there. I think we have, at our health system, have used those templates, put them on our intranet for nurse manager resources. But stay interviews, the purpose is, it's the opposite of an exit interview, right? And that you just really want to have a sense of the goals of your staff. And if you're establishing a rapport with them, and I would say we do stay interviews at least every 6 months, but I do know managers that do them more frequently, at 3 months, and then maybe at 6, and at 1 year. Obviously, through your performance evaluation, you're also asking similar questions, and essentially it's around the goals that staff have. And if you have a clinical ladder, it also helps you kind of guide them to whether they want to be on the clinical ladder and advance in clinical education management. Where are their passions and their strengths?
Thank you. The next question is related to are clinical ladders still effective as a retention tool?
Right, that's a good question, and it's a national conversation right now in nursing. Typically based on Benner's model, novice to expert, clinical ladders varied in terms of their intent and how they're operationalized. So we actually at Hopkins are really looking at all the evidence and asking across our hospitals, how we're operationalizing clinical ladders. And our newer generation of nurses really want to be developed quicker than what we're used to in the Benner model, right, which is around experience only, and really looking at competency-based incentives. So I would say that, yes, the clinical ladder still can be a retention tool, but it's not the only tool in your toolbox. For instance, at my institution, we're very odd, evidently, according to our consultants that I engaged, because we have everybody on the clinical ladder. So everybody has to be, we have many steps on our ladder, rungs, if you will. But there are a lot of institutions that you can choose to climb the ladder or not. And just, the or not is just be an excellent clinical nurse because of your other commitments or passions. So that's something we're looking at. But clinical ladders really, I think, are most effective from the research I've done when they are tied to your succession planning for the organization, not just for nursing. And I think typically we've been pretty siloed with just looking at them as nursing tools for advancement, right? When you look across your organization and you have people that are, very, very good at safety and quality issues, they're not, like again in the talk, there are people that probably are very good at that, but they might not be good at the operational piece. So they're not someone you want to be in charge of a shift, but boy, wouldn't you want them part of that interdisciplinary team looking at falls with injury or pressure ulcers or CLAPSI. So the clinical ladder really should be developed around core competencies and kind of the kind of leadership responsibilities that person wants to take in the organization would be my suggestion. Because along with that, you can have a menu of other ways that nurses can be incentivized to do things, for the betterment of patient outcomes. Many people tie certification and other things to their clinical ladder. That makes sense, especially if you're an organization that's on the magnet journey and you know you need to have those structural pieces in place. So I would say yes and to answer that question.
Great, thanks. Next question, how do you accommodate this new generation workforce while maintaining satisfaction and safe patient care?
I'll take that question. Thanks. And I think it's a very interesting question, and actually follows up well, I think, with Dr. Baker's answer about clinical ladders too, that it depends. But this new generation workforce, many of us refer to, millennials. We have Gen Xers. We often have 3 and 4 different generations within our workforce. But working with the new generation, I think there's a couple things that we can do as leaders. They have a lot of experience working with teams. That's been a lot of their educational backgrounds, and we need to encourage this. And within healthcare, we really do focus on interprofessional and teamwork as an important aspect of what we're doing with the discharge planning, the discharge processes, lining up resources and evaluating care. And so bringing them together with the other professionals that they're working with obviously can really increase safe patient care and their satisfaction within the work setting, because it's an experience that they're comfortable with. I think another thing, another thing to think about with millennials is that they're awaiting their next challenge. And so when you kind of think about transformative leadership that we're talking about, and the idea of how to make change happen in an organization, these nurses can be our best allies, the new generation workforce, because they want to progress, they want to network and function in these teams. The key is that as the transformative leader, the leader of the group, you need to provide leadership and direction to them so that then they can kind of, run with the questions, run with the investigation, the exploration of what the problem or the issue is. I think maybe one other thing that to accommodate this new generation workforce, and this isn't always an easy thing to do in nursing, is flexibility and providing some flexibility for staffing, for the way things are done, and allowing them to challenge. Question, is this really the way we should do it? Here's some kind of new ideas. And as long as the group can get to some, consensus and evidence base in what they're doing, we can provide, I think, that flexibility in the work setting, and hopefully improve their satisfaction with the work environment and still maintain that safe patient care. So those are 3 things. I guess there's one other that I thought of, and that has to do with feedback. And this group of our new generation, I think, is a group that really prides themselves on doing a good job, and so providing feedback to them is something that I think they would value as they look to progress within the organization, whether it's through a clinical ladder or through task force work or shared governance work that is in each of their units or their departments. But using those skills that they bring to the work environment that are different than the other generations that they're working with.
I'd like to just add one more thing, only because it's just something I've learned along the way recently, and that is this is a generation that really is used to not having to say in person, give feedback in person to one another because of the technology. We have ICUs where young residents and nurses text each other across the same unit, and they're all on the floor together. So one of the things I found really helpful, because it's a learning need they don't know they have, but once they engage in it, they're pretty jazzed by it, and that is peer-to-peer review. So having them review each other's practice and have to give feedback is a real skill that they develop, and it's transparent, right? Whether it's a central line dressing for CLAPSI, following the checklist, or whatever it is, that I watch your practice, you watch mine, or I go across the unit and watch one of my peers' practices, and then they come over and watch mine, and then we give each other feedback. At first, I would think that would be so intimidating to a generation that texts feedback, but in two dimensions, right? They're never really three-dimensional. But it's been very well received, and you're talking about how do you maintain safety, which is really a great question. So that's one way you can maintain safety, right? They own their practice, they're giving each other feedback, and they know how to give each other feedback. Whereas sometimes a generationally different person, someone much more better than them, giving them feedback may not be the praise they're looking for. So it's just something, lesson learned along the way.
And I could even add, I think, to that as an educator, with our online course environments,
right,
the discussion boards, the posting of clinical logs, and the evaluation of each other's works within either group or section happens on a routine basis. And so again, it's that idea of them working in teams and the experiences that they've had, and they have also experienced giving feedback to one another and educated that way in a different way than other generations before that they're working with.
Yeah, pretty great.
Great question.
Thank you. So our last question today comes from the point of view of a staff nurse. Question is, how do I, as a staff nurse with no real authority, initiate and motivate change when my nurse manager is the one who is most resistant?
This is an excellent question, and not just for a nurse, right? In every walk of life, we are going to be challenged with having to manage up, I think is the colloquial way of saying that. And that is the very person or persons in leadership are the obstacle to change. So I think the best answer to that question, or just a pretty relevant answer, would be that it's through relationships, right? So obviously, expressing intention and actually coming from a place of good intention to the manager is really important. And then it's, there's a whole bunch of informal leaders on any unit in any area of work. So it's really those informal leaders coming together and prioritizing what their values are and what change they wish to see. And usually, we know this, so if you just bear with me for a second, you think about the analogy being in an organization where nursing wants to move something, but the hospital executives aren't ready to do that. Well, we're such a large workforce that when we get together and come up with a process and get our data and get our ducks in a row, if you will, and present that, and we start moving in a direction, people will follow because we're so large and so impactful, and we're there 24/7. So if you take that down to a unit level, and there are many members of your unit, and nursing units are diverse, right, diverse levels of staff, coming together around a common goal, it's very difficult for a manager to resist that. And that usually works. It's a little slower than having a champion manager that wants to move it ahead, especially tapping into every manager has a deputy, has an assistant nurse manager, has a layer of leadership that they rely on, engaging that group. And if that fails, then the other thing in nursing that we have that is pretty consistent is a chain of command, right? So I mean, how many times I'm a CNO, right? I may get somebody and they don't know how I feel about a position, but maybe they're anticipating that I would be resistant to it because they've seen resistance in the organization. Then plenty of times people have gone to the COO or something and pitched something on rounds as a nurse and saying, I don't know if nursing leadership would go for this, but I think we should do this. Right, and that person comes back to me and tells me that, and that's good, right? That's working the room and working all the leaders that you can. My one piece of advice is don't stop trying. That's the most significant thing. So there's always everybody has a boss, right? So that person has a boss too. But usually through good information, having the data and the evidence for why the change should happen, and having good relationships with people, you usually can manage one person being resistant.
And I would just want to add, I think there too, that as a staff nurse, you're at the point of care.
That's right.
And you're the person there 24/7, 365, and a nurse manager who's resisting your ideas for change and getting back to some of these other questions about satisfaction and safe patient care and some of the things that we talked about with the value proposition for nursing that it brings to healthcare and a healthy work environment. you have to be able to discuss those things, and that's where you can really influence change at that level and possibly even up through the organization, the policy changes that I was talking about. But you're the one who knows what things work, what things don't work, and as you begin to try them out, that's I think it's a critical role for a staff nurse, so never negate it.
Yeah, and as I hear you talk, Kathy, one thing I forgot to say was, if you keep it focused on patient care and you keep it focused on the patients, and if you include the patients, if you have a patient family advisory council or something you want to take your idea to and you get momentum there, it's just like I make the analogy, it's not a very pretty one, but I'll say, even in a bad divorce cannot be so bad if we focus on the kids, right? But I think when there's disagreement in the hospital between roles, I always say focus on patients and we will compromise. We will get where we need to be.
Thank you so much for such an engaging and excellent presentation today, and thanks to all of our attendees for your time today.